So hello, I'm Dr. Peter Goverde. I'm a vascular surgeon um, working in Antwerp in the ZAS hospital group, uh, mainly doing endovascular and uh, open surgery um, and dedicated to peripheral occlusive disease. Yeah, as you still know or already know, the CERAB technique is still a very young technique. Yeah, um, it's just started to be used around 2010, and there is still a comparison needed between the classic aortobifemoral prosthesis surgery and also the use of kissing stents in an endovascular manner. Yeah. Um, But in the beginning, we actually started to follow up the patients. Um, so for short, midterm, and long-term follow-up, yeah, and also the technique itself and the construction itself were based off different investigations. So we actually built our own flow model with uh, so uh, that is comparing the traditional endovascular solutions with the CERAB. And all were actually in favor of the CERAB configuration or reconstruction. Yeah. Um, as I said in the beginning, it's still a very young technique compared to the octobifemoral prosthetic implantation. Yeah. We still need more data about the patients. Yeah. Enlarging of the patient group, more long-term data, and maybe also a randomized controlled trial. Yeah, because for the moment there's still not a randomized controlled trial that, for instance, compared CERAB to autobifemoral prosthesis implantation. Yeah, and I think, and then mainly for the industry and research for industry, I think the building of the creation of dedicated devices for the treatment of aortoiliac occlusive disease is also one of the key features that we need. So this trial gives us the first really long term. So it's 10 years results of the CERAB trial, and we have already the short term, the 3 years, the 5 years. And but for the moment, so we will have 10 years, and this is very important to recognize and see which possible factors that influence those 10 years of outcome, and also when we compare that to the classic open surgery, but is still in many centers the golden standard for treating aortoiliac occlusive disease. Yeah. And one of the important things of this study is that all patients were included. So patient one, so where the first CERAB was implanted, to all the rest that are actually were selected for implantation are being followed. And as we already know from the previous studies, most of the patients are very old, yeah, and have multi comorbidities, and are, let's say, much sicker than the average patients for peripheral disease. And that was also the reason why the follow-up was actually started from the beginning, so that we could retrieve as much as possible data to maybe correct in time either the reconstruction, the construction, or devices. As I said, we started from the beginning, so it's actually a physician-initiated, in the beginning, more retrospective, but then mainly prospective follow-up study. Yeah? So we try to understand as much as possible regarding the patient's patient demographics, the follow-up, and the construction, the devices to, let's say, correct in the future maybe, or do a better patient selection, or to see if the patient population that can be selected can be enlarged. So most of the patients, as you already know, are TASC C and D lesions. So patients with extensive aortoiliac disease. In the beginning, so actually the main population of this study group was actually unfit for surgery because of obesity and hostile abdomen, or previous abdominal surgery, or too high morbidity or comorbidity. All patients were actually treated with the original technique, meaning that they received one aortic stent and two iliac stents. So later on, we did some changes in let's say the stent placements, but that was mainly in the general findings where we actually go from healthy to healthy tissue. What we also did is that a very thorough follow-up, mainly done by duplex scanning. So every three months the first year, and then twice a year. So till now, yeah. And also the follow-up of the classic vascular symptoms and evaluation of ABI. Yeah. So we also could find possible risk factors. So in this first population, there are a few risk factors that can give you a higher chance of being a patient of CERAB. Smoking, still the majority of the patients are smoking when they have their intervention. Also, a large population, around 40% of diabetic patients, and then they have also cardiovascular comorbidity, like previous carotid surgery of peripheral vascular surgery, and also they have, and that's a very vast group, hypercholesterolemia. So this is a very high predictor of aortoiliac occlusive disease. Yeah. Also, the Radcliffe Becker classification was used to determine the severity, and the majority of these patients are still Rutherford Becker class 3B, so actually the worst claudicants. And then regarding previous interventions, so they had more or less in 50% already previous peripheral interventions, with more than 70% of those people having stents already placed in, and they have also received cardiac interventions, being classic cardiac surgery or PTCA in around 50% of the patients. So what we actually found, and let's say was actually very encouraging, was that the patency, first of all, the patency rates, of course, compared to the patency rates from the previous studies, or study results, the 3 years the 5 years that we actually presented in combination with my colleague, Monsieur Reinen, and the equipe from Rijnstadt Hospital. So the primary patency rate was still, after 10 years, 67%. If you compare that to the 5 years being 77%. And also the primary patency, assisted patency was actually encouraging with 78% when you compare that to the 88% in the 5 years study. And we have still a very high secondary patency of 82%, where in 5 years it's still 95. So also what we found was that we had freedom of clinical driven target revascularisation of target lesion, revascularisation of more than 75%, what is at 10 years a very good result. Yeah. So meaning what the effect is of prediction, and also what we said before, we saw that patients had a better outcome when they had no previous interventions, mainly in the iliac region, but also in the peripheral region. And also the previous stent placement was actually creating a worse outcome than no surgery at all. Also the effect of the progression of the peripheral atherosclerotic disease. So if that is actually almost not present or very going slow, then there was also a better outcome seen in this population. Yeah. So and what was actually giving a slightly better results was age and being treated as a claudicant or as ischemic disease, meaning with wounds or with breast length. In terms of possible problems or perioperative complications, that was already more or less described in previous studies. So that's not completely different than these studies. Yeah. But also the influence of the long-term results was during the follow-up already an indication to slightly improve our technique, meaning using more stents and going from healthy to healthy tissue. Whereas in the first group that we actually studied now, it was always 3 stents, so 1 aortic and then 2 peripheral iliac stents. But we actually in time we actually changed that in as much as possible, and also treating near distal disease, meaning external iliac and common femoral disease also in the same or in a short second period. We changed the amount of used stents, meaning that we use the amount of stents that was necessary to go from healthy tissue to proximal. So we're going from a healthy aortic zone to more or less healthy iliac zone or even common femoral zone. Because we saw that progressive distal disease is actually having a negative effect on the outcome of the and the patency of this reconstruction. Also very important is that Now, following these patients for more than 10 years, we can see that the complication that we actually encounter can be treated with endovascular techniques. So it's not necessarily needed that when the CERAB fails, you have to convert to an open procedure. It's still possible that the CERAB reconstruction can be saved or treated with endovascular techniques. Also, on terms of patient selection, what I also mentioned earlier. So because it's a safe technique, we also incorporate younger patients. Yeah, and also, of course, the main component of patients being all patients that are not fit for surgery, but the patients and let's say can have a benefit now with using the CERAB technique and avoiding a classic aortobifemoral prosthesis implantation, where you need a longer hospitalization, sometimes ICU, a few ICU days, and especially also a longer hospital stay. Right? I think in terms, but that's also maybe a good idea for the future is to compare it with traditional aortobifemoral prosthesis and the outcome of them. Also, what we changed is, or actually where we maybe a little bit inconfirmed, is that the follow-up, so our duplex strategy, so meaning every 3 months in the first year, and then every 2, and every year twice a duplex ultrasound can actually predict or foresee possible problems, so that possible complications can be dealt in an endovascular way, and let's say also preventing occlusions, and so treating more stenotic disease. So let's say maybe what we can conclude now with the results of this first 10 years of CERAB patients is that those are still very encouraging when you compare that to the traditional aortobifemoral prosthesis. Yeah? But although it's optimistic and giving positive results, I think we need still a larger population and more centers that actually present their data, so that we have a larger population that we can compare with the traditional, so the aortobifemoral prosthesis implantation and kissing stents, so that we actually can say this is a better reconstruction with certain indications. I think follow-up is still very important. You know? So every patient that receives a CERAB, I think we need to follow as long as possible, trying to understand possible benefits and also possible disadvantages, because with every technique there are probably also disadvantages. So we need to, and we want to know that. And I think also for the companies, I think there is still a market, and there is also a necessity of having dedicated devices to deal with this sort of pathology and using the CERAB technique.